rotators. You start working on those. Now remember when we did our initial assessments on them last week, we had them on the table and we did our range of motions with those again. All right, again, so what I'm going to do is I'm going to do these again. I'm just going to bring her foot up. I want you to take this foot towards your other leg. There, okay. So she's actually not too bad. If I hold her hip down, that's where it goes. So she falls a little bit short of that. If I let the hip go, see how the hip will raise up and then she can go all the way over. But if I hold the hip down, we stop probably about 10 degrees. Not bad. So she's not too bad in there. And actually there it goes now. So it's just a little loose in there. And if we have her bring it out here, she's just maybe a little bit right there. But not too bad. So what I want to do is I want to work on the muscles. Now remember when we did the encapsulitis work?
Yes.
When we did it from that side? Sometimes you'll actually find more on this side than you will on the other side. So it would be the same thing when I'm doing my assessments here. If I found that bone-on-bone end feel again, like it would want to stop in that position, I can do that same work from here just by doing it from here. From here I can now push up in like I did before. Tractioning it back out again, taking it back up, doing the strain, counter strain techniques here. And pulling it down. And then the plunging action is whatever which way. If I can't get the leg to move this way, then I'll be up and this way. If it can't go this way, then I'll be going up and in this way. So I'll just pretend that she can't go this way. So it's just up in. Up in and plunging it in, and then my last one will be in and giving it a nice mild fascial stretching in there like that. And many times that'll work. All of my runners, I do that work on automatically, even if I don't feel a bone-on-bone end feel. All of my older clients, I do that on. Because again, this is what's going to happen. Everything in the joint capsules and everything is going to start stiffening up more and more as we get older. We don't have the fluids going through there that we do when we're younger and all that stuff. So this will just help to loosen all that stuff up in the hips. That's why I always do that work. So, but if we have somebody that can't say this is as far as you can go, what would restrict that range of motion? The range of motion that does that, no, that's what's going to do that motion.
The restrictor would be the internal rotators.
Would be the medial rotators, yes. So that would be the ones. So the medial rotators would be what?
Minimus.
This, yeah. And medius.
Yeah.
TFL, yeah. Gracilis.
Yeah, could have a little bit in the adductors, could be a little bit in there, you know, but basically it's going to be right in here. This is what's going to restrict it in there, okay? So that's where I'm going to go in and work. And many times you're going to go in here and you're going to get in here and you're going to feel ropes. You're just going to feel little ropes in there. She's got a little bit of one right there. You feel that? Yeah. So there's just a little bit. Sometimes these are going to be very painful. Again, this was the hip that was higher. And where does this come from? Comes off the top of the pelvis right there, and it comes over and attaches to the head of the femur right there. So what's happening? As it's being shortened and tightened all on that side. So if this side is shortened and tightened, again, this one over on this side is going to be stretched out and weak. Okay, so this is going to be ischemic, not a lot of blood flowing through there, you know, nerves are going to be compressed, everything's going to be compressed. This can be really painful on people in there. So always, you know, when I get in there, I want to make sure. You okay with that? You okay?
Yeah.
You okay? Okay, yeah. But I'm just going to go in here, and really all I want to do is just go in here and loosen this up. That's really all I can do. I can't fix anything in here. I can't cure anything or anything else like that. But the best thing is I can do is I can loosen up this muscle so I can get the full range of motion in the hip again. So I'm going to go through there. Now again, if I find one of those ropes in there, what can I do? I can press on it and ask if it refers away from it. And that would be a trigger point. And then I can do the trigger point therapy. You know, hold direct pressure. We do it for like 10 to 15 seconds is what we do ours in this work. And then, you know, so I can do my, you know, and if it's not, you know, if it just stays local to where that is, again, then it's just a tight muscle in there. So I'm just going to work that. So I'm just going to go through that tissue, just kind of working all the way up and down through that tissue until I get the desired effect that I want there. Or to where it feels like, and a lot of times you can start going, if I start working, I see, is that starting to feel a little bit better in there now? Yeah, so once you just start working, you'll usually get some fresh blood flowing in there again. That'll just make everybody happy. Then when we do that, you know, I can just go in there and just do some nice compressions in there through that hole. But again, it helps to remember where your muscles are, where they are, so you know where you're working. That's the glute medius is going to be right in through here. The glute minimus is underneath there, so when I'm pressing in there, I'll be affecting that too also. Okay? So, a lot of times after I can do that, and one of the other things, I love traction. I think traction is some of the best stuff that we can do on the human body. I always just, you know, anytime I'm passing by there, I'm just going to give them a little tug like that. Because what do? We open up space in the joint, we get fluids to go into those hip joints, we take pressure off of the joints themselves. So anytime you can do it, and again, if you can see, I'm doing this with my body. I'm letting the, you know, my body just pull it back again. And when I go back, I do it gently. I just don't pull it out and then let go and let it, you know, because then that could just make everything just lock back up again. So just doing that. And then when I'll do it, and most of the time once we do that, we'll be able to move it and it'll go much easier. Even just doing that again, it was going to stop a little bit short. Now it wants to go nice and easy. Can you feel a little difference? Yeah, it moves a little bit easier now. If it wouldn't, say if we still only got about right there, you know, but it was, I can stretch that, and the way that we can stretch this, just like we do any of the other stretches, I would have her press her leg against my hand, press this way. Okay, go ahead. 1, 2, 3, 4, 5. Relax. Nice deep breath in. And exhale. And usually then we can get a nice little more stretch out of that right there. And again, if she did complain about a lot of pain on that, I could test it to see if there's a sprain strain in there. And that would be, I would just have her press against my hand right there. And if she had a spot, she could point right back to it again like that. And what would I do? I would go back in. I would do that multi-directional frictioning. You know, and the same thing, and then do the eccentric muscle contraction, where the eccentric muscle contraction would be for her, which would be which way?
Medial or lateral.
Yeah, so she's going to give me the resistance, and then I'm going to stretch it out. I want to stretch the tissue out. So she's going to be pressing up. There we go, yep. And just let me win, let me win, let me win. And then so we would just do there like that. And then we could just go. And then just fine, and then we would retest it again. So. Okay, so that's how we would do that way. Now, say she doesn't come this way. She gets stuck here. If it's a bone-on-bone end feel, I would go back into the hip. I would do the hip capsule work first. And then once I got that, then it would probably just be more of a muscle stretch. And hers is a little bit tight right in there. And so again, what's going to restrict that motion? It's got to be the lateral hip rotators. Now, they're not, because they won't release to allow that leg to go all the way back through there again. All right, so I'm going to do the same thing. Now, you know, this is where they all are. They're right here. All your lateral hip rotators are going to be right in through this area. So that's, you know, the biggest one is, you know, did you ever notice how some of the books will say piriformis and the other lateral hip rotators? They're like the, you know, the stepchildren or something like that. You know, they don't really talk about a lot of them in there. But so I want to go, so this is where they can go. Now I can just do some like nice little right in there. You can feel that a little bit, can't you?
Barely.
Barely, okay.
P, go quick. No, that's, yeah.
But this can be sciatica. This can be people that have, yeah, as we get down a little bit, you can feel a little bit more right in there. Now, people that have piriformis syndrome, do you know what piriformis syndrome is? What is sciatica really, though?
Inflammation of the nerve.
Most of the time, it's an umbrella term for hip pain. You know, that's, you know, so you'll hear the old, oh, my sciatica's after that. Most of the time, it's not sciatica.
Most of those are self-diagnosed.
Yeah. So they just have, well, it's just hip pain. So they just call it sciatica. That's what they all call it. And there's doctors that do the same thing with it. You know, again, you have to understand. Did I tell you that? Most doctors get about 2 to 4 hours of training in musculoskeletal pain when they go to school. Sad, isn't it? But that's all they get. So they don't really know it. So what are they going to do? What's the doctor going to do? He's going to send you to a neurologist or something like that if you complain about that hip pain in there. But again, the piriformis, the sciatic nerve, when it comes through, passes down and through there. Most people, it goes underneath the piriformis. Some people, it goes up on top of the piriformis. And then some people, it goes right through the piriformis. So those are the people that, where it goes through the piriformis, the nerve, those are the ones that usually will get the piriformis syndrome.
It doesn't always?
Not always, no. No, it's dependent. I forget what the percentages are, but it's most of the people, the majority, I think it's 60-some% goes underneath, another 20-some% it goes up on top, and then the rest of it goes through the middle. right, goes through the belly of the muscle there. So why it happens, you know. Again, some people have more bones than other people. Do you know you have less bones when you get older than you do when you're younger? And some people, I forget, there's a bone, where is it? Somewhere in the pelvis, that some people have it and some people don't, so they're not sure if it's something we're growing into or if we're going away from. They're not really sure yet because they haven't been able to study it for very long. So, all right, so now there's other techniques. So there really are some of the research is showing the bottom of the lateral hip rotators is the quadratus femoris. And because it's at the bottom, it comes off the ischial tuberosity and comes over to the head of the femur. The sciatic nerve goes on top of that. So what happens to a lot of people is when the pelvis starts going like this, it pushes the quadratus femoris up into the sciatic nerve. And that's causing more people to have the numbness and tingling going down into the leg or pain down in the leg. Now, we had a doctor that came in and talked to us at one of the classes that I took, and he told us that true sciatic pain is only felt below the knee. So if it's anything in here, it is not sciatic pain. Doesn't mean it's not another nerve that's getting pinched, but it's not sciatic pain. It's only going down in the leg. Now, I had it real bad a few years ago where I would just get this burning going right down through the peroneals, or perineals, however you want to say it. And I would just, especially after a long run or anything like that, it would really hurt really bad and stuff like that. And especially if I sat in my car or if and this was when I was going to massage school, so I couldn't sit. How do you sit in class all day? You know, that was fun. But I found out that if I could sit on a tennis ball and stick it right in that spot, that would relieve the pain for me on there. So again, trying to find where it is. So again, if you got somebody that has some of that shooting pain down there, and we go in there, you know, because many times if they have some of these things, if I would just press on there, that might get the symptoms to show up down in the lower leg. And it may not show up there, but if I come in here and I find out where the ischial tuberosity is, and I know that's the head of the femur, so right in between there is that quadratus femoris, so I'll just go in there and press into that, and then I'll ask them if that causes any pain, or they feel a little bit. So it's probably a little tight right in there. Again, it's one of the hip rotators, so it can be right in there. And again, I could be pressing right on the nerve, too, a little bit, because that's where it's going right over the top of that.
Lateral rotation.
Yeah. Yeah, so, all right, now, if you go see Dr. Eric Dalton, who does the myoskeletal alignment techniques, he's got a real nice way of releasing the piriformis muscle. It's basically, I know where the piriformis muscle is going right in through here. I can go up in here with my elbow, and what I'll do is I'll just push the piriformis muscle up, and then just rotate the leg. And what that does, you can see the muscle would be here, so what will happen is the muscle will just kind of bend right around my elbow, and it's just like a pin and stretch technique that you can get it to release the piriformis. But again,
Muscle up.
What's that?
Pushing the muscle.
I'm not pushing anything. I'm just setting my arm there, and I'm just letting it take it, and it's kind of bending it like a green twig. So this is the muscle. I'm taking the muscle like this. By moving this, and this is just kind of forming around it, and it's just it's just a pin and stretch technique. I'm pinning it down. So it's kind of like taking something and going like this with it. That's what I'm doing with the muscle.
Traveling straight.
The muscle is going here, right? But by pushing, this is where this goes up like this, and then and as I bring it over, it'll turn. Let's see how the whole thing is going to turn. And that's a nice way that you can release piriformis muscle on that side. He does it real fast. I think he does it something like this, where he gets in here and he pulls the leg this way and things like that. I could never figure it out, but he's been doing it a lot longer than me. So again, I would go through there and just get all that to release in there. And then bring the leg back up again. See if it's going to move a little bit farther for me. And then I can stretch it, so go ahead and take your leg away from me. 1, 2, 3, 4, 5, relax. Nice deep breath in, and exhale. And then just take a little bit more again. Now if I want to test it again, I can have her take her leg towards the other one. If she had any pain, that would be in the piriformis right there, you know, or someplace like that. Again, finding muscle strains in these muscles, usually don't find that many of them. But again, if there was one, we would go in and find. And most of the time, if you're going to find them, it's going to be right on the attachment places up here or here. We don't usually find them in the muscle belly, again, unless they've been in a horrible accident of some sorts or something like that. You know, a football player might or something like that if they're getting, you know, slammed into or anything else like that. And again, then if we had to, then we just go
The
into
trigger point will usually be in the belly though, correct?
correct. Not always. Here, I think you'll find, actually, if you look up there, I think you'll find a few more of them right on the attachments up there, if I'm correct on that one again.
Attachment.
Yeah, they'll have one on the little bit of the attachment itself. Yeah.
So, and with the plunger movement, if you do have a hard end stop or feel on medial rotation, you plunge the opposite direction. You're plunging the opposite direction, or wherever you have a hard end feel.
If I have a hard end feel, then I'm going into the joint capsule first, right? And whichever way it won't go, so if it won't go this way, that's the way I work.
Okay,
Towards
so
that,
towards
the
that.
restriction.
Okay,
I
gotcha.
always work towards the restriction on that.
Okay.
Right? So, okay. All right, so go ahead and take your clients and let's do a little bit of their hip work.